Hello everyone, I'm Ko-Ting Chen from Chang'an Memorial Hospital, Taiwan. Today I'm going to share our study on the combination of navigation-guided focused ultrasound and bevacizumab for patients with recurrent glioblastoma. Recurrence is an inevitable fate in GBM patients. Despite maximal safe resection and adjuvant therapies, these patients always recurred, especially at tumor margin with a median progression-free survival of 6 months. Since the protocol, the survival for GBM patients has substantially improved. However, the 2 years overall survival was still less than 20%. Therefore, bevacizumab since 2009 has been approved to be the standard of care in recurrent GBM patients. However, upon literature review, we found the PFS of bevacizumab in recurrent GBM patients only 3 to 4.8 months. The 6 months PFS was less than 50%. One of the main reasons for such a poor survival is the blood-brain barrier, which significantly impedes drug penetration into the brain. This is especially true for malignant brain tumor patients, since there are heterogeneous permeability and presence of efflux transporters. The FUS guided BBB opening has been proved since 2001 in preclinical model to be targeted, reversible, and safe. Thereafter, numerous studies have using the FUS BBBO to enhance drug delivery to the CNS system in various disease models. We therefore use this mechanism in human patients. For these phase 1 clinical studies, we use Neuronavigation-Guided focused ultrasound system and prove it to be safe in a non-rigid manner. Besides, a precise and transient dose-dependent BBB opening has also been shown. How about combine FUS BBBO with bevacizumab? In our previous study, we found a significantly enhanced CNS concentration of bevacizumab of 5 to 50 folds, which translates to the increased median survival for up to 135%. We therefore initiated this clinical study. This is a phase 2A single-arm feasibility and efficacy trial since 2020 until this year. We use a biweekly FUS-BEV treatment, totally 38 weeks with up to 18 FUS-BEV treatments. The primary endpoint was 6 months progression-free survival. There are two technical advancements. One is we use a larger exposure unit than our previous phase 1 trial. Since our treatment target was the resection bed, we use this circumferential manner to deliver treatment units for each patient. Besides, we apply the acoustic emission feedback and acoustic emission mapping technique to precisely deliver the FUS energy. For further technical details, please refer to the ID 72. Here are the planning and results. All the treatment targets were planned by neurosurgeons before treatments. The ROI were set to be on the resection margin to cover both residual enhancing and non-enhancing tumors. Here are the results. We can see in these 6 patients, the treatment locations were over frontal, temporal, parietal, and insular lobes. The number of FUS targets was 6. The median treatment times was 14.5. Of the 6 patients, only 2 patients has progressive disease, making the PFS since FUS-BEV treatments 9.5. There were only few side effects related to FUS treatments. In this study, we had median PFS of 9.5 months. 6 months progression-free survival was 83%. FUS-related adverse events was less than 2%. There were no intracranial bleeding, no seizure, no infection within FUS-BEV regions. Besides, we aim to analyze the serial change of flare signal in serial MRI. Therefore, we overlay the FUS-treated beam path areas to the MRI to analyze the signal intensity. For flare signal intensity analysis, we divide our regions into FUS-BEV regions, which were marked in red circle, and BEV alone regions in blue circle. And we also identify the internal control as a white circles to check the ratio of FUS-BEV versus BEV alone regions. In each patient, we had a serial MR imaging signal intensity follow-up, and here are the intensity change of each patient. After pulling all the data, we found a significantly flare normalization effect since 4 sonications, meaning 1 month FUS-BEV treatment, and this effect persisted to at least 4 months. On the other hand, the FUS-BBBO for treatment in glioma has been applied and widely checked. However, the FUS acidic diagnosis has recently been raised as a liquid biopsy or sonobiopsy. We therefore check the plasma brain-derived materials before and after FUS treatments, which show that up to 2-fold of EGFR positive brain-derived materials or cell-free DNA concentration before and after FUS treatment. We next check the correlation between the FUS energy and the FUS coverage volume with this enhanced ratio for each patient and each sonications. First, the estimated transcranial pressure was poorly correlated with the cell-free DNA ratio. However, by adding the acoustic emission feedback, we found a gradually enhanced correlation coefficient for this CFDNA ratio. The same was found in the AEM model. In conclusion, FUS-BBBO is feasible to combine with Bevacizumab repeatedly for treating recurrent GBM patients. A significantly normalization effect of flare hyperintensity has been observed in FUS-BEV versus BEV alone peritumoral regions. FUS-BBBO enhanced liquid biopsy or sonobiopsy has been confirmed, and the concentration of cfDNA was better correlated with real-time acoustic emission feedback data. The PFS in this study was 83%. The median PFS was 9.5 months, which was encouraging. Therefore, more data are needed to prove the therapeutic effect of FUS-BEV for recurrent GBM patients. With that, I would like to thank our team and all the team members and the funding support. Thank you.